Black Doctors Podcast.
Hello, welcome back to the Black Doctors Podcast. I am Dr. Stephen Bradley, your host. By training, I'm a critical care physician, anesthesiologist, and medical ethicist, and that will be the subject of a lot of today's episode. Thank you so much for joining us on the show every week. It really means a lot, and the feedback and the ratings and the support that I get really provide some motivation to keep going. So many folks that reach out that are weekly listeners. Dr. Lavanani, one of the nurses that I work with, Shakia, told me she listens to the podcast. And for all you folks kind of in different parts of your careers, whether it's pre-med, medical school, residency, or even an attending physician, I do try to make every episode relatable and helpful to your practice or to your future as we all kind of go down this path of being a healthcare provider in some way, shape, or form. Or at the least you'll interact with healthcare professionals in some fashion at some point in your life. And hopefully this kind of helps close the gap, maybe, I guess, humanize us and help you realize that we are all out here to kind of make the world a better place. And we're here for good patient outcomes and health and safety for everybody that we are privileged to work with. This week, we're talking about medical ethics. One of the things that has come up recently, if you're on Twitter, in the last week, there was some drama with a post from a Neil Khosla. He's not a physician, from my understanding. He is a co-founder. He's a CEO at Cure AI. Cure AI is a company that is deploying machine learning and clinical workflows. Cure AI Health is an AI-powered virtual clinic delivering primary care to more people at a fraction of the cost. And he posted a portion of an article by another physician, and the article is discussing full body MRI scans. You've probably seen ads on social media, or you've seen ads on when you're watching your shows on Netflix or YouTube. You know, they like to skim through your phone and see what's going on and then target marketing based upon what you just discussed or looked at. Big Brother's always watching. So these full body MRI scans, you know, or CT scans, it's the same kind of concept. It's not really new. It's been around for decades that you can go somewhere and have these therapies if you're paying out of pocket. Usually you have to go to a physician. You have to have an order or a prescription for these different imaging modalities. Usually you're paying with insurance. Insurance isn't going to pay for a full body CT scan or MRI just to look and see what's going on or what could possibly be going on. So there's always been this market for, hey, if you want to pay out of pocket, you can go somewhere and get this scan done. So now with the birth of, or the rebirth and advent of AI in healthcare, everybody's searching for a way to put this into use as well. So now you can merge the AI read of these imaging scans, and then they'll pick up all these different disease processes and other things that you can look for. So this CEO of this Cure AI company reposted a snippet from an article that another physician had commented on, and he labeled her comments as paternalistic. Essentially, she was advocating against or talking about how it's not such a good idea to have everybody signing up for these full body MRI scans because of very valid reasons, misunderstanding the results, the anxiety that comes with having a potential diagnosis, the incidental lomas, those things that are found that we now need to treat. And now you've subjected people to even more kind of healthcare encounters. So the original tweet that came to my attention was from this Neil Khosla guy. He says, just a wild amount of medical paternalism from a physician via at Chrissy Farr's latest piece. I guess Chrissy Farr's a journalist or something. Whatever this instinct is that suggests consumers can't be educated on their health, it needs to go away. And he posts a clip of this article that, again, allays this physician's concerns. It was by Dr. Nisha Patel. She is a obesity physician and internal medicine physician. And she kind of talked about some of the dangers and ramifications of these full body AI scans and then, or full body CT and MRI scans. And this is all part of a bigger conversation about private equity, about venture capitalism and its effect on healthcare. You've got all these people that are building startups. They're not physicians. Most of them, they're not clinicians, but they have an idea that's going to revolutionize healthcare and also make them a lot of money. And they're trying to figure out how to bring these ideas to market. So they'll have a team of physician consultants that are kind of helping them guide these steps. So if you're a physician that's making a ridiculous amount of money consulting on these companies, sure, you're going to be slightly encouraged to help them bring these ideas to fruition. Anyways, now we have some feedback from another group of clinicians, and it's labeled as paternalism. If you read the piece and the response, it's a huge thread, you realize it's not really paternalism. This is a group of physicians even that share their thoughts on this specific issue. We, as the majority of physicians, would probably recommend against a routine full body scan because of all these subsequent issues that can bring up. The incidental findings that lead to further treatments down the line that may or may not have been indicated in the first place. So that's the underlying issue. But the concept of medical paternalism, it goes back to the theme of medical ethics. And one reason I really haven't been too active in posting about it, because it's very difficult to discuss these concepts of medical ethics. And when there's a character limit, it's hard to talk about this on Instagram and on Twitter. Again, maybe I'll make some videos on the YouTube channel that I was going to relaunch last week, and then I was in the ICU for a week. So I'm just now getting caught up. But anyways, this week on the show, I'm going to talk about medical ethics, kind of what that means to me, how I've incorporated that into my career, and why I think it's important for us all to get involved. So starting off with my pathway, I am a medical ethicist. I was first exposed to the field as a resident. I was at the University of Chicago, and they have the McLean Center for Clinical Medical Ethics. Dr. Mark Siegler started this, and he actually was responsible for coining the phrase clinical medical ethics. He's a former intensive care physician, I believe. So as I was going through residency, I'm doing anesthesia. We also rotate. I spent almost 6 months working in the ICU. As you can imagine, there are a lot of very complex family dynamics, complex social situations, complexities of medical care. Saw some patients, had a patient on a total artificial heart, different issues that come up with transplants, and, the 30-day and 60-day outcomes and how long patients are alive for, the justice and the distribution of resources that come with people that are receiving transfusions every day, but have very little hope for a meaningful neurologic outcome, the moral distress from physicians and providers and nurses for taking care of patients when they can't see the big picture. So all of this really got me thinking about the field and how can I get more information on how to make these very difficult decisions. I was fortunate that at the University of Chicago, there is this McLean Center for Clinical Medical Ethics. They offer a 1-year fellowship. So I was kind of stuck. Do I apply to be a chief resident in the coming year, or do I try to take this 1-year ethics fellowship? I reached out to one of my mentors, Dr. Elizabeth Blair. She's an ear, nose, and throat surgeon at the university. And she said, hey, you do this ethics fellowship, it can really change the trajectory of your career. The chief year or chief responsibilities, maybe not. It doesn't really get you far, maybe a little bit of leadership experience, but you also get that later on in your career. So long story short, I applied and was accepted to this ethics fellowship. It consisted of a month of didactics. So summer going into my 4th year residency, we spent about a month with almost daily meetings during the week. We spend hours going over lectures with lawyers, philosophers, parishioners, clinicians, physicians, and learn about the basics and the background of clinical medical ethics. That was the focus of this fellowship. Clinical medical ethics is kind of a sub-segment of the field of bioethics. Bioethics is kind of much broader and deals with a lot of stuff that happens outside of bedside medicine. How do we make these policies on a large scale? It's a little closer to the philosophy side with Kantism and go on and on. And brilliant people. But for the clinician, we usually have a much more limited discussion. We're not necessarily debating philosophy at the bedside. We're talking about medical issues. So clinical medical ethics kind of falls under the realm of a broader bioethics framework. So we spent a month doing these weekly lectures. And then over the course of the next year, we rotated through the ethics consultation service, covered several weeks. And once a week, we would have a ethics case conference. And that was probably the most impactful portion of this fellowship, where we would sit in a room on Wednesday afternoons for like 2 hours, and we would discuss 2 cases that were seen as ethics consultations in the prior months. This was helpful because the cohort we were with, we were able to kind of grow together. We were able to feel very comfortable sharing our different ideas and our different perspectives, even things that were controversial. But then we would apply our different perspectives to these different ethics or ethical dilemmas and come to some solution. We had fantastic leadership and mentorship, people that had been in the ethics space for decades, and they were there to guide us. And we would have incredible conversations. And it was so awesome to see different perspectives that were there. When it was a surgical issue, the perspective of a surgeon who's going to cut and heal disease versus the perspective of an internist that usually deals with a much slower progression. And then you mix in the pediatrics folks whose patients can't necessarily always consent, and maybe they're able to assent to different procedures or services. And then we had input from chaplains and from basic kind of translational science folks. And over the course of the year, had some crazy, complicated ethical scenarios and situations that came up. One, I remember we had meetings with probably 8 or 9 different consultants. I think for one, we had consultations with maternal fetal medicine, endocrinologist, intensivist, obstetric anesthesiologist, cardiac anesthesiologist, neurologist, neurosurgeons. Of course, you had social workers and chaplains. And we had all of these different specialties and multiple family members. And it was just a fantastic learning experience, and able to actually help, hopefully, patients is the goal. So I finished the 1-year program with the McLean Center, and also finished residency at that point in time. I then transitioned to life in the Navy. So I went to boot camp for a couple months, was stationed in Norfolk, Virginia for 4 years. I was able to get involved in the hospital ethics committee there. It was very interesting because once you sign in to become an officer in the military or enlist, little do you know, you actually signed up for kind of a different code of ethics. I have a lecture that I give that actually talks about the medical ethics involved for active duty service members. Things like HIPAA and patient privacy are a little different because you've signed up and you are subject to the mission of your unit or to the military at large, and your commanding officers and different people in your chain of command have the precedent to be involved in your medical history and your medical care, say when things can or cannot happen, in regards to surgery, talk about when things can or cannot be disclosed, like mental health, if you're supposed to guard national secrets or nuclear launch codes or something like that, then your mental health and other issues do become kind of a matter of national security. So it was a very interesting dynamic and kind of a shift in the ethics that I learned. I remember very vividly, I was a junior officer. I think it was when I came on, I was a lieutenant, right? 03. And so I was the most junior person on the ethics committee. There was a bunch of very senior officers, some retirees, which in the military, like you'll retire as a senior officer, 06, a captain or whatever. And then you stick around and get a civilian job because you have your military benefits, and just kind of, you get grandfathered into the system, and you still keep a lot of your rank and your respect. It's kind of I think a lot of companies do that, but it was very obvious in the military. So I remember one of the first consultations was about a service member who'd had a psychiatric break and they needed to be medicated against their will. They were in the psychiatric ward being held in the middle of a psychotic break, and the command had reached out to their family and their medical decision makers and all this. And we discussed when would we treat over patient objection. And we had like an hour-long conversation about this. I'm like, okay, this is great. And after we had this discussion, this former captain who was kind of working for the hospital now and was still involved intimately in the hospital affairs says, okay, we'll just discuss with the commanding officer of the hospital and see what he wants to do. And I'm thinking to myself, well, why did we just spend an hour talking about this if ultimately it's going to be up to the commanding officer, which based upon Navy policies and procedures, that's accurate. So it was very interesting to serve in that regard. I was able to do the ethics work at my hospital in the Navy, Naval Medical Center, Portsmouth. And then I deployed for 5 months in the hospital ship, the USNS Comfort. We were doing humanitarian aid missions in Central America, South America, and the Caribbean. I've spoken about that on a previous episode. I don't know if it's easier to refer you to the prior episode or to just make a new one talking about my experiences on deployment. Maybe that'll come up in a couple months. So I was able to do some ethics work on the ship. And it was nice because since I had this training, people very quickly found out okay, you do a lot of ethics work. And they started to come to me as a resource. We didn't have a formal ethics committee on the deployment, but I was there as a resource for people to bounce ideas off of and get another perspective. It was nice that even outside of the ethics committee, I had partners in the Navies, the CRNAs, the anesthesiologists I worked with that would come up to me and say, hey, what do you think about this patient? We considered them for surgery. They got Versed for a nerve block, but they didn't sign their consent form. What do we do? I'm saying, and my answer was, I know there's the administrative policy that we need consent signed, but the patient already verbally assented or verbally consented to the procedure, and consents are not a signature. Consents are a conversation of risk and benefits and accepting of risk of a procedure. So it's ethically permissible to proceed with this surgery. Whether you'll get dinged on the backside for a policy violation at the hospital, that's another thing. The alternative is to sit and wait for this patient to recover. One of the highlights of my time in the military, I did spend a month in Guantanamo Bay. So I was there at the Naval Hospital, Guantanamo Bay. That is separate from where they keep the prisoners. I know they like to call them detainees, but they're prisoners that have had some sort of trial. They've been there for, 15, 20 years by now. There's still quite a few folks, I'd guess about 15, 20 or so, that are still detained at Camp America. That's a new facility they built. First was Camp X-Ray. That's where in the beginning of the wars, you would see prisoners being sent to Camp X-Ray. It literally looks like a prison camp. I was able to drive around. I have some pictures somewhere in my phone of Camp X-Ray. It's all overgrown in the bushes. So then they built Camp America. So they bring down Army reservists, and they're the ones that staff that facility. There's a small medical clinic there, an OR as well, but you only go there if you need to do medicine or provide surgery anesthesia to the prisoners or detainees. So I didn't actively engage with any of the prisoners, but I did give a grand rounds talk about medical ethics to the staff of the hospital. So that was overall pretty well received. During the research for that, a lot of it details with forced feeding of inmates. And as I was reading, this is several years ago, what I eventually uncovered was that whereas the American Medical Association, American Nurses Association, different governing bodies for healthcare workers, we agree that it is unethical to force feed people against their will. When they're of sound mind, they do have the capacity and the autonomy to refuse being force fed. But you can go to the states and you look at our prison system and the governing bodies of our prison industrial complex, and the force feeding is allowed. So basically in the US, we can force feed the people that we've locked up in these for-profit prisons if they're on hunger strikes or whatever, whereas the American Medical Association and our governing bodies for healthcare providers say it is unethical to do this. So you have the policies of our overlying organizations, but then you have the individual clinicians who can also make their own judgments and say, hey, as a physician, I think it's okay to drop a feeding tube and feed this prisoner against their will. And so to get around that, I know in the beginning with Guantanamo Bay, there was, I believe, at least a nurse or a couple nurses that said, we refuse to force feed these prisoners. And there were some legal situations and maybe getting fired or not getting fired. And they ended up working this out in court, but that precedent was set. So I don't know that I'm not saying that there weren't physicians and nurses that were force feeding these prisoners, but there's also all these workarounds where you can have medical techs, medics. In the military, we had corpsmen, and they're under kind of their own governing body, right? Because they were built by the military. So there's the corpsman's creed and all that stuff. And the corpsmen aren't beholden to the ethical policies of the American Medical Association, American Nurses Association, et cetera. They're their own entity. I don't even know what their policies state, but it's probably something that aligns with whatever the government wants them to do. So they would be the ones, by and large, to provide these feedings to inmates. One of the nurses I worked with in the Navy was a prior corpsman, and their job was to feed prisoners down in Guantanamo Bay. And the way they described the setup, because we know what we saw and heard in the news, but essentially there's different types of detainees down there. Some people that I guess we were more sure were bad guys, and then some that were like, maybe not, probably were a little bad. I don't know, who knows? Because they just got scooped up out of their neighborhoods in the Middle East and then sent around the world to probably various CIA black sites, and then ended up in Guantanamo Bay so they could stand trial for whatever it is that they were accused of doing. Anyways, there were some really bad dudes and then some not so bad dudes. And the way my buddy described it was the really bad dude said, hey, we're going to go on hunger strike. And they forced everybody else to go on hunger strike along with them, with fears of violence and reprisal, whatever. So the folks that weren't really on board with the hunger strike used the force feedings as a means to get nutrition without violating the rules of the hunger strike. And again, per my friend who was there, he says they would actually race and say me first and like ask to go first with the tube feedings so they could get nutrition while kind of maintaining the hunger strike and not being victimized by the quote unquote really bad dudes that were also locked up. Anyways, I digress. That was the whole Guantanamo Bay experience. So again, my eye-opening with regards to medical ethics. After my time in the Navy, I was able to go back to the University of Chicago, and I was able to rejoin the McLean Center. So I was doing my critical care medicine fellowship. And for the year, I was a senior fellow at the McLean Center. So once again, I was able to sit in on the weekly lecture series and case conferences. And then I was able to cover the ethics consultation service. A lot of the thing about being an anesthesiologist, and especially a critical care anesthesiologist, is so many of these patients with complex medical decision-making and ethical dilemmas come through our hands. So the number of times that I was actively involved in patient care for a patient that was also an ethics consult was astronomical. I would say like 40% of the time that I knew patients we would talk about the week before. Next thing I know, they've had surgery and now they're in the ICU, or I saw them on ethics consults. Now I'm seeing them in the ICU, or vice versa. So another reason why I think this is an integral portion of what we should learn, especially if you're an anesthesiologist or critical care physician. So I was able to do another year of the fellowship and now moved on to my job down in Florida. In the next month, I plan on taking a certification exam provided by the American Society of Bioethics and Humanities to hopefully become a health care ethics certified consultant, HECC. So I've enjoyed the journey thus far. Now, why did I get into medical ethics? It was twofold. One was a complicated medical decision-making I was exposed to. The other was this need for representation. So if you look at medicine in general, it's not very diverse. You look at the field of clinical medical ethics, it's even less diverse. A lot of people just aren't exposed to this. And when you are exposed to it, it's because you're in over your head, you're asking for ethics consultation, you're going to ask for a medical ethicist, and they're going to provide this distinct value. Some people reach out and they're like, hey, I don't know what decision to make. Or they'll reach out to us to like tell them if the patient has capacity or not. That's not our job. That's a psychiatrist's job, really. As a physician, you are able to determine capacity for your patient. That's a free gem. If you're in doubt, then it's good to have a second opinion, which can be another physician partner. Or if you're really jammed up, sure, call psychiatry. But realize when you call a consultant to determine capacity in your patient, you're asking somebody that knows the patient even less than you do to come and render a judgment about their capacity. I digress. So when you're asking for these ethics consultations, I have this book because I'm studying for this exam One of the studies, they found that approximately 5% of all individuals performing ethics consultation in the U.S. hospitals had completed a fellowship or graduate degree program in bioethics, while 41% had learned to perform ethics consultation through formal, direct supervision by an experienced member of an ethics consultation service, and 45% had learned independently without. So when you're getting these ethics consultations, half the time, you're asking somebody that learned the job. And hopefully they've read books and they've studied and they've seen a lot of different ethics scenarios, but they may not have formal training in medical ethics. The beauty of a fellowship, and there's different ways to get this training, whether it's ethics fellowship that's offered at different hospitals, highly recommend University of Chicago. As you're looking for different residency programs, really think about what other things they offer. Masters in education or public health or public policy or different fellowship programs. So this was a ethics fellow. There's also master's programs and doctorate programs in bioethics. So those are available as well if you want to go deeper. But as few as 5% of medical ethicists have achieved this formal training. So almost 50% chance you're going to consult somebody for medical ethics about your patient that has these complicated decision-making processes, and you're going to have somebody that just learned the job. Not, speaking down to their efforts, because thankfully they're invested and motivated. But I wonder, without the formalized training, how much individual bias is infused within that consult. So you already have a very sticky situation, and now you're asking somebody, and they're going to potentially be more biased if they didn't have formal training. The beauty of the fellowship program and these master's programs and doctorate degrees is you're immersed in a cohort, and you're able to see all of these different perspectives, people from different backgrounds, and it helps decrease your inherent bias and provide unbiased consultations for these very, very difficult situations. So I encourage you, we need more representation in the field. A lot of it is on the job training. So what can you do as a medical student? Look and see if your medical school or hospital offers a medical ethics elective. Especially, it'll be great going into your fourth year when you're looking to just chill and not really do much. Usually there'll be some form of student representation on the ethics committees. These typically don't involve too much time because most places there's not a lot of ethics consultations that are going on. But you'll be able to go and sit and hear how people discuss these cases. You'll be able to hear the incredibly biased takes or the incredibly well-rounded and thoughtful takes that people have. And you'll be able to start building this knowledge of clinical medical ethics. As you go on to residency, you can fall back and say, hey, I rotated in medical ethics as a student or at your job, because now you have some ethics experience, which is, again, 50% of people learn on the job. So you'll actually have that and be able to use it, and it will provide credibility, and you'll be in the room helping inform these decisions that are directly affecting patients. So next time talking about medical ethics, I'll probably jump into some of the more common ethical scenarios that we encounter on the consultation service. Usually these are things with informed consent or medical decision makers, the quote unquote futile care, something that comes up a lot. And in the meantime, there's always resources that you can use if you want to learn more about medical ethics. The American Society of Bioethics and Humanities is kind of a bigger organization and a little more on the philosophy side from my experience so far. I've only been a member for 2 or 3 months, but there's a book, Clinical Medical Ethics. Here we go. There's a book, Principles of Biomedical Ethics by Tom Beauchamp and James Childress. Excellent book. It's very deep. It goes into a lot of the philosophy behind clinical medical ethics. And then there's a book by Dr. Siegler. I just happen to have these in my bookcase, just arm's reach away. Clinical Ethics, a Practical Approach to Ethical Decisions in Clinical Medicine. So this is kind of a fantastic book to get you started in medical ethics. It breaks down how you should approach different consultations. I'm always around. Would love to chat if you have different complicated ethical situations. The beauty of this is not medical advice, but you can ask hey, what would you have done in this situation? Or what should I do next time I encounter this? Always happy to help and be a resource. And stay tuned for future episodes. Let me know what you guys want to hear. What questions do you have about medical ethics? Thank you so much for tuning in to the Black Doctors Podcast. Future episodes, hopefully, plan on getting Michael Johnson of Michael Johnson Legal back He's a lawyer, specializes in physician contracts, and I know he's helped quite a few of my friends. You got to pay the man. All these lawyers and stuff, regardless of if you use Michael's services or not, you got to pay for a lawyer. But Michael has been kind enough to come on the show multiple times, and I know he's helped quite a few of my colleagues out. He helped me out, answer some questions as well. And he reached out. It's like, hey, this whole non-compete situation is coming up soon in the courts, and we're going to get him on to discuss what does that mean for our future as physicians. So that's coming up in future episodes. Also looking to get Dr. Brittany Halford and Dr. Altalicia talk about money, finances. Always can learn more about that. Thank you so much for tuning in and joining us every week here on the Black Doctors Podcast, because representation matters.